The broadcast is now starting. All attendees are in listen-only mode.
Hello, everyone. Thank you so much for joining us today for our live chat. My name is Lakelyn Hogan, and I am gerontologist and caregiver advocate with Home Instead Senior Care. Our live chats are brought to you by Home Instead Senior Care, a network of locally owned franchise offices. The Home Instead Senior Care Network offers in-home care with an individualized approach to keeping your older adult loved ones safe and independent at home. And to learn more, you can visit homeinstead.com. And before we dive into today's topic, I always like to go over a few housekeeping items. So first and foremost, we have muted all of your lines. That way it allows you to go about your day. Maybe you're at home doing dishes or at the office with some chatty coworkers in the background. No worries, we cannot hear you on our end. So we will keep those lines muted throughout today's webinar, but we do want you to ask questions. So we have a questions box on the screen. Please feel free to type in a question at any time. Don't be shy. It's likely that other people have similar questions as you do, and we find that all these questions that you type in are really for the greater good of our audience. So please don't be shy. At any time, you can type in a question. And finally, you don't have to worry about taking any notes. We are recording today's webinar, and we'll send you a link in a follow-up email after today. And then if you liked the chat or wanted to re-listen to it, you can, listen to it again, share it with family, friends, somebody that you think might really benefit from the information that we are talking about today. So those emails will be sent out again following today's chat, and we'll include all of the great resources that come up throughout today's hour in that email. All right, so I think we're ready to get started. Historically, we have focused these live chats on Alzheimer's disease and Alzheimer's caregiving, but we also know that many of you listening and in our Alzheimer's community are Facebook followers. They are caring for loved ones living with other types of dementias and other types of neurodegenerative diseases. So this year, we're trying to diversify these live chats a little bit. And today, we're going to shift the conversation from Alzheimer's to frontotemporal degeneration. Frontotemporal degeneration, or FTD, you're going to hear that acronym thrown out quite a bit today. And as you can see there on the screen, that is the acronym for frontotemporal degeneration. It's kind of a mouthful, so I'm glad there's an acronym to go along with it. So FTD is a group of brain disorders that differ from other types of dementia. And we're really fortunate to have with us today an expert on this topic, and she's going to dive deeper into FTD, and answer questions that we have from the audience. We also had a lot of great questions come in on our Facebook page. We had no idea that we had so many people affected by FTD in our Facebook community. So we'll incorporate a few of those questions as we go about today's hour as well. So I want to introduce you to our expert, Sharon Denny. She is from the Association of Frontotemporal Degeneration. She is the program director and leads the association's support and education efforts for people with FTD, their families, and healthcare professionals. Her priorities include ensuring the responsiveness of core services and expanding the availability of FTD-specific resources and support. She has introduced initiatives that address the needs of children and teens and individuals diagnosed with FTD. For the past 6 years, she has led a committee of clinicians and family caregivers who produce Partners in FTD Care, an FTD education initiative for community healthcare providers. And Ms. Denny has a master's degree in clinical psychology and more than 26 years of experience in program development for disability organizations. And she has been with AFTD, the association, since September of 2008. So Sharon, I want to welcome you to today's live chat and thank you so much for joining us.
Oh, thank you very much for the invitation, Lakelyn. It's really a delight to be with you.
Well, I feel the same delight, and I'm really excited to learn more about FTD. I know we were just talking before we went live with the audience about how a lot of times people don't know all the different types of dementia and neurodegenerative diseases or how FTD might differ from Alzheimer's disease. So I thought before we take questions from our audience, would you mind kind of breaking it down for us a little bit, talk about the differences between FTD and Alzheimer's disease, just so we kind of have a good baseline to go from? That would be super helpful.
Absolutely. So, and I would imagine that based on the other trainings that you've done, that your audience is pretty familiar with the idea of dementia in general. But that's often where we start, because dementia is the largest umbrella term. And dementia really is describing a change in behavior and cognition that affects how a person functions in their day-to-day life. So under that really big umbrella of dementia are different things that cause those cognitive and behavioral changes. Some of those types of dementia are actually reversible. There are some that are medical conditions that can be treated and reversed. But when we're talking about the neurodegenerative disorders, these are progressive diseases for which there are no treatments. And of course, the most common one of the dementias, the progressive dementias, is Alzheimer's disease. Alzheimer's disease affects approximately 5.5 million people in the US. So it's a large number of people affected, and our public conversation increasingly is recognizing the impact that dementia is having in terms of healthcare and in terms of the needs of families and caregivers and the burden that comes along with that. So if we look at a different part of the umbrella, under that dementia umbrella, we also have disorders like frontotemporal degeneration, Lewy body disease, and some other types of progressive disorders. So frontotemporal degeneration is actually itself another umbrella term. So you have to kind of picture now a little smaller umbrella, even within dementia as a whole. So FTD actually refers to several progressive diseases that affect the same parts or the same circuits of the brain, and those would be the frontal lobes and the temporal lobes, and the circuits that run between them. So frontotemporal degeneration disorders have in common changes in thinking, changes in decision-making, planning, control of emotions, executive functions, things like that, that go along with the frontal lobes, where we do a lot of our analytical thinking and where a lot of our social behavior is housed, and also the temporal lobes. And the temporal lobes are the parts of the brain that are critically involved in language and speech and kind of interpreting the information that our senses take in. So the frontotemporal degeneration disorders are a result of disease in these particular parts of the brain. So how is FTD different from Alzheimer's? FTD starts younger. There's really three ways that the frontotemporal degeneration disorders are different from Alzheimer's. And first and foremost, FTD is a younger onset disorder. So FTD is the most common form of dementia for people under age 60. There are some people who develop Alzheimer's at a younger age, but it is much more common that FTD has an onset under the age of 60. It's really one of the characteristics of these disorders. Secondly, we tend to think of Alzheimer's as being a memory disorder. That's the hallmark symptom that's associated with Alzheimer's, and the parts of the brain that are affected first and foremost are those that are in charge of memory. That's not true in FTD. So FTD is not primarily a memory disorder. The frontal and temporal lobes of the brain, as I mentioned, are really in charge of different types of behaviors and different types of thinking. And so it is personality, behavior, language, and in some cases, movement or motor skills that are affected first and most prominently in FTD. And the third way that FTD differs from Alzheimer's is that it's relatively rare. So, if Alzheimer's affects 5.5 million people, the best estimate that we have right now is that FTD affects about 50 to 60,000 people in the US. So a lot fewer people. And what happens really is if you put these three factors together, that it is a younger onset disease, that it is far less common than Alzheimer's, and that the symptoms are much harder to kind of put your finger on, much harder to identify, and much harder to understand. Those three things together make for a really, really difficult and particularly challenging disorder for the individuals affected, for the families affected, and for healthcare providers to be able to serve.
Sharon, thank you so much. That was very, very helpful. And I like how you broke that down for us into, those three kind of main differentiators. And it's so interesting to learn that FTD is more of a younger onset, and to learn that it's more common in people under 60 than perhaps Alzheimer's disease is, and then those symptoms are harder to understand. So I know we had a question come in from Ken about kind of the diagnosis. So I know in his case, his wife had Alzheimer's and then also got a diagnosis of a frontotemporal variant of Alzheimer's. And so he said, can you please elaborate a bit more on the fine tuning of her diagnosis? And I know you're not a physician, so I'm not asking you, of course, to diagnose her by any means, but can you, I guess, maybe speak more generally to the diagnosis process, or what families who are going through this can kind of expect in terms of a diagnosis journey?
Well, and that's very well put, because it is a journey, and it's often a very, very bumpy journey for people to get to a point where they're actually receiving an accurate diagnosis of FTD and one that they can have confidence in. It's really difficult. There aren't any tests that a doctor can do right now that would say, oh, we know for sure this is what you have. So the term that's used is biomarkers. There's no blood test. There's no single imaging test. There's no particular screening test that can allow an individual experiencing changes or their family to know for certain very easily at all that this is the right diagnosis, and especially early on. So if you go back to what some of the things are that are changing for someone, a lot of times someone, the things that they're going to report or that their family members are going to notice are changes in personality. So instead of being really consistent and being able to go to work and work at a high level every day and be able to interact with clients and master lots of details, they may have trouble following through with tasks that had been pretty routine. They may have trouble keeping themselves organized in terms of being able to, they start to miss appointments, or they skip appointments, or it's just much harder to keep up with the details and the demands of work. The personality changes are also really insidious, and people may recognize that their loved one has started to use language they never used before. They've started to be more inappropriate in terms of how close they stand to people, or they may say more rude things to folks. These are just sort of uncharacteristic changes that aren't necessarily things that would point to, oh, I think my loved one has a really serious neurological disorder. Very often, in early stages, FTD is misdiagnosed as depression, or as bipolar disorder, or potentially as another type of a psychiatric disorder, because the symptoms are kind of diffuse and hard to pinpoint. Over time, what people see is that they become more extreme. So people's judgment may become impaired. You may see folks who are spending large amounts of money, or buying large quantities of the same thing, or hoarding items, or picking up cans, or lots of strange behaviors that the family is saying, gosh, this just doesn't seem like the person that I married. I don't know what's going on here. Apathy is a very common early symptom that people will experience. And so you see all these personality changes, or there may be difficulties in language, but they very often aren't identified as serious medical issues until the family has been through the ringer for a long period of time. Primary care doctors have a hard time identifying these symptoms as a neurological disorder. People may be treated for depression with antidepressants for a long period of time and lose a lot of time before they realize those treatments aren't actually helping or changing anything, and that some of the behaviors are getting worse. And so it does tend to be a very long journey for many people. We know that from some of the studies that on average it can take up to 3.5 years for someone with FTD to get a diagnosis. And part of that is needing to kind of go through ruling out many other things, making sure that folks have a chance to get to a neurologist, to get to a specialist who is knowledgeable about the range of possible diagnoses that might be coming into play, and then to be able to really go through a whole battery of tests. And so to diagnose FTD really requires looking at a very careful history of how do these symptoms develop and when, and what else was happening for the person at that point in time. To look at then a complete medical evaluation, a neurological evaluation, to rule out any of the possible reversible courses, reversible types of dementia. Neuropsychological testing can be very helpful in identifying the particular types of thinking skills that may be impaired. A lot of times in FTD, you might see a really mixed profile on a neuropsychological eval, where some people have really strong intact skills in particular areas of their thinking or their language or their memory, and other areas are really quite uncharacteristically impaired for someone who had reached that level of functioning. And then brain imaging is the other part of a diagnostic workup that's really important. And so being able to take a look at the brain from either an MRI or a PET scan can provide the specialist with additional information through which they can see then, does somebody meet the criteria for diagnosing an FTD disorder? But it is a really bumpy journey. And the question that you started with in terms of refining a diagnosis really does require trying to get to a specialty clinic where the doctors are going to have seen a lot of people with different types of dementia. Because while someone may learn about the criteria of these disorders, being able to actually assess the whole preponderance of data from the evaluation requires that level of experience. And that is where it's particularly challenging, because again, these are rare diseases. There just aren't that many physicians in most communities who've had experience with FTD.
Wow, thank you so much. I mean, I was jotting down notes feverishly because you were giving so much rich information, and those kind of early signs. Yeah, I'm trying to put myself in a caregiver's shoes, and seeing those signs, you would probably be wondering to yourself, you know, like, this is so unlike them, and what could it be? Or and so I could see how it could be kind of that long journey that you described to get a diagnosis and finding those specialty clinics. I know we had a few people write in that they're in more rural communities, so there really aren't specialists available, which can probably be very frustrating for caregivers when they're trying to look for a diagnosis. Does the Association for FTD, do you have resources to connect families with physicians or specialists in different types of these types of neurodegenerative diseases?
So we have really strong relationships with the folks who are doing in-depth work in FTD disorders. And what we're able to do is tell people, we know that these academic medical centers have a lot of experience in FTD. And so where people are able to consider traveling to get to one of those centers, we list them on our website, on regional pages on our website, in order to try to help people. For those people who may suspect there's something wrong, they may be looking for a second opinion, and they have the ability to travel. Now, we know that's not everybody. So where that's not the case, we will try as best we can to share resources that we are aware of at the state level or in the local community level. We also have a really good network, a growing network of volunteers and support groups. And through them, we're able to connect people down at the local level to try to find those pockets of experience that we may not know about at our national office, but that we can kind of rustle up for folks through networking, you know, down at the community level.
Wonderful. And we'll be sharing the website here in just a little bit on our resources slide. So if you're listening and wondering what their website is, we're going to be sharing it here in a little bit. But that's really good to know that the website that you have at the association has those kinds that kind of information. So thank you so much for sharing that. And we have continuing questions rolling in about the topic of diagnosis. I know we probably want to move on in just a little bit to some other areas of conversation around FTD, but Aisha had wrote in and she said that, is it possible that a patient in their 50s may have been misdiagnosed with FTD if they displayed severe personality and motor changes, but also experience memory loss consistent with Alzheimer's disease? Or are there dual diagnoses that are possible?
Well, not being a physician, I have learned that all things are possible with these diseases because they really don't follow many rules. So I wouldn't rule out that it's possible that someone might have legitimately meet the criteria for Alzheimer's and for FTD, but that would not be my first guess. I think because so many doctors don't have experience across the board with having seen a number of patients, I think sometimes it may be very difficult for them to settle on this is what it is. It would entirely depend on what are the elements of the evaluation that were done and what did they show. So for example, if brain imaging shows that there's a loss of brain tissue in the frontal and temporal lobes of the brain, that can add confidence to making a diagnosis. But brain imaging doesn't always show that. So especially early on, an MRI might not show that. So each of the different parts of the evaluation can kind of give the doctor different information that might add confidence or might just kind of continue the lack of clarity in getting a diagnosis. Many, many folks with facing these diseases also face the challenge of not knowing for sure. Again, because we don't know how to say for sure this is the pathology causing the disease. All these diagnoses are based on clinical symptoms, which are often very difficult to pin down with the same kind of confidence as people would like. There's another aspect to diagnosing these disorders, Lakelyn, that I think is really important to mention, and it's, especially when people are experiencing behavior changes, the parts of the brain involved also affect self-awareness. And so many people who are experiencing changes in their behavior may not be aware of it. And so again, the family's role is really important in diagnosis. The family as a reporter and as an observer of these changes is critically important. The nature of the disease when it affects the frontal lobes is that people might not be aware of their own changing behavior. They might not go to the doctor and say, hey, I think I'm having this problem, because they don't see it. The family has to be a really good advocate, which takes a lot of courage and takes a lot of persistence, because it happens that, as your loved one may be experiencing these changes, they're not necessarily going to say, oh, thank you for pointing that out to me. They may not see it, and they may not be as open or as willing to engage with the medical community as they need to be. And that can be a huge challenge and an obstacle, especially for folks with what we would call the behavioral variant of FTD.
Thank you for sharing that. That's a really great point, that families are so important. I think families, no matter what type of dementia, a lot of times they are the first to see the changes in the person or to notice them. So it's important that they are involved in, like you mentioned, in good communication with the healthcare provider, if and when at all possible. And we actually had somebody that has asked a question that's kind of relates perfectly to what we've been talking about. Amanda just wrote in and said that her husband was diagnosed with, and I'm not sure what this acronym stands for, so Sharon, you might be able to better, elaborate on it, but it's B as in boy, V as in Victor, FTD. So BV FTD about a year ago. And she says, my husband has always lacked empathy. I think he might be, or he says he's always lacked empathy. I think he might be right, but it's difficult to tell since I was only with him for 24 years and now he's 52. So she says, how often do those diagnosed with FTD lose their empathy many years before diagnosis or before obvious signs? Or is it possible that they were born with it? So I guess I kind of paraphrase Amanda's question. Is a lack of empathy a common symptom of FTD? And then also, I guess, she doesn't directly ask it, but this, brings up a good question in my mind is how long does FTD usually last for a person, or I guess, can you kind of speak to the duration of it? I know it probably varies from person to person, similar to Alzheimer's disease does, but is there kind of an average length that somebody is expected to live with FTD, or does it truly vary? So sorry, I gave you a very complex question there, Sharon.
No, it's all right. I wrote some notes down. So I'm going to go back to Amanda's original question, and the acronym. We do have just a slew of acronyms in this world. And so I'm grateful that I wasn't the first one to bring too many of them up. So BV FTD is actually the behavioral variant of FTD, which I was just mentioning. So in behavioral variant FTD, this is where you see the most prominent changes in a person's personality and their behavior changes. Their decision making is eroded. They may have impulsive kinds of behaviors or inappropriate social behavior. They may develop repetitive behaviors. So what you see in behavioral variant FTD is that the most prominent things that are changing are how the person relates to others and how they're able to kind of carry out the planning, organizing, and appropriate social behavior in day-to-day life. And so, yes, empathy is very, very often impacted in behavioral FTD. And in fact, we have a resource here called Partners in FTD Care, which you mentioned in the beginning, Lakelyn, and we did a whole issue on the loss of empathy in FTD. So if somebody is interested in that in particular, please just contact us and we're happy to point you to that. So it is very common, we'll think of behavioral variant FTD, especially as affecting the social brain. So a lot of the symptoms really do have their impact on relationships, and certainly the loss of empathy is one. Some of the examples that would come in terms of what people notice is, and it's surprisingly common, somebody will tell us on our helpline, that their mother-in-law passed away, and when the husband went to the funeral, they just didn't seem to be expressing any loss or any sorrow. Or that, the children in the home are really excited because the prom is coming up, and, daughter is looking for a dress for the prom, and dad really just couldn't care less, or mom couldn't care less, and shows no interest, shows no understanding that the relationships that have connected a family before are different and changing without explanation. I think part of your question was how long before the diagnosis would you see that? That's, of course, harder to answer. Usually one of the diagnostic criteria is that what the symptoms are reflect a change from the person's prior behavior. So if the empathy level was kind of always the same, you'd need to see noticeable changes in other areas that would go into making a diagnosis of FTD. So again, it's not impossible that someone's empathy has always been limited, but that alone wouldn't support a diagnosis of FTD. You're really looking for where are things that have changed over the person's prior behavior. And it's those changes and the history of those changes that can figure prominently in understanding and making a diagnosis. And then in terms of the duration of the disease, FTD is not one disorder. It goes back to it being an umbrella. And so there's a lot of variability and a lot of variation in how it presents, the symptoms that people might have, and there's variation in the course of the disease. So from a statistical standpoint, we always say that the average length of progression is 7 to 11 years that a person may live from the time of diagnosis. That life expectancy would be between 7 and 11 years. But it's so variable that some people with particularly aggressive forms of FTD may live 2 years, and others may live more than 20 years. So there's great variability in terms of the duration of the disease and the rate of progression of the disease.
Thank you so much for answering all those questions that I threw your way. You handled that very well, Sharon.
My notes are
I
good.
appreciate you're a good note taker. Well, I appreciate everyone that has typed in questions. It's just my heart goes out to all of these family members and caregivers because it just sounds like there's so many challenges that come along with the diagnosis process, and I mean the sadness and the emotions that come along with seeing a loved one change from the person that they once knew to the person who was having all of these symptoms of FTD. And I kind of want to shift now our conversation to the symptoms. We've gotten a lot of questions through our Facebook page about the different symptoms. And I know we've talked a lot about how everyone is a little bit different in their journey with FTD. And we had Michael, he just wrote in, and or Michelle, pardon me. She says, my husband has FTD/PPA. So that might be another acronym you have to explain to us. But she's saying, I'm finding it impossible to bathe him. I know it is pretty common, but any advice is appreciated. So earlier, Sharon, you talked about that maybe the self-awareness is decreased in some forms. So does that affect how people care for themselves? Or can you talk a little bit about bathing or maybe that personal hygiene and how FTD affects a person's ability or willingness to bathe and make sure that their hygiene is in order?
Sure. And I'm going to define the acronym first.
Okay, thank you.
So PPA is the acronym that's used for primary progressive aphasia. And so one of the ways that FTD presents itself is with changes in language. So sometimes people have early prominent changes in language, and they can take different forms. They have more trouble sort of articulating words, or have trouble finding words, or they lose the meaning of words. And so there's a variety of ways that early language problems can show up that may be an indicator of what's called primary progressive aphasia, one of the FTD subtypes. So I'm going to guess that the person asking the question about bathing and self-care may be in the middle of the disease course and not so much at the early stage. In the early times for someone with primary progressive aphasia, they're usually still pretty well able to take care of themselves and their own needs and personal hygiene and whatnot. And the early stages, the first year or so, is usually really marked by language changes, but the person does not lose self-awareness. In PPA, they're aware of what they're losing, which has its own tragic consequences, and people can have much more of the depression and the experience of loss in those symptoms early on. But as the disease progresses with all of these disorders, you begin to develop symptoms in other areas of functioning. And so it is very common that someone with PPA over the course of the disease would start to develop symptoms more common to the behavioral variant, or other changes in behavior and daily and their abilities to take care of daily living skills. So that trouble with bathing and a loss of involvement in self-care is pretty common in behavioral FTD, and then as PPA progresses, it would be common too. What's behind it? Well, there's a certain amount of apathy that's very, very common in the FTD disorders. And so some people think that part of the difficulty in self-care and bathing is related to apathy, just not caring. That, again, this is a symptom of the disease, that being able to sort of engage in goal-directed behavior is harder if you can't plan and organize, or if you don't care about sort of the social aspects of what's happening around you. And so it's a direct result of what's happening in the brain. And that's, of course, an oversimplification. That's not going to be true for everybody, but these are factors that can go into why people lose that interest in self-care. Sometimes folks where there are more behavior challenges also become resistant. They don't want to be told what to do. They don't want you to direct them. And so what do you do about that? Well, the best way to try to intervene with those types of behaviors is actually not verbal. whether the person has PPA or another type of FTD, using logic and verbal direction is probably not going to be most effective. So what we need to do is think of communication with that person in a much broader sense. How can you set the stage in a way that's going to make it easier for them to take care of some of these self-care needs? How can you guide or gently direct them through nonverbal ways? So sometimes people really try to make it more physically appealing to take a shower, whether it's pairing that with some music that the person likes, or making sure that the room itself is a comfortable temperature and that it's easier from a sensory standpoint to be able to take care of personal hygiene. So again, that's kind of covering a lot of bases, but I hope that in some way is helpful in terms of understanding what's behind some of those self-care challenges, and then looking for different ways in the environment and in sort of behavioral interventions that are not going to rely on what we all tend to most, which is verbal direction, because it's not as effective in this case.
Sharon, thank you for those tips. I think that sounds like it could definitely be a kind of a game changer for someone who's been trying to verbally guide their loved one through the bathing process, but to think of it differently, use more of a nonverbal form of communication. Hopefully, Michelle, that you find those tips helpful, and hopefully those tips are helpful to other listeners. So thanks, Michelle, for writing in, and thanks, Sharon, for that great answer. We just have questions rolling in on this topic, so this has been wonderful. If you have questions, and if you've joined us a little late, you can type them in at any time. We have another question that came in from Mike. He says, what about the speech loss variant? My wife seems to have both behavioral and speech problems. So it sounds like, I know you've talked a little bit already about how FTD could affect someone maybe behaviorally or in terms of language. It seems like for Mike, his wife is experiencing both. So is this also a common form or situation for someone with FTD?
It is. And again, the symptoms develop differently in different people. So someone who starts with language symptoms, with difficulty articulating words and whatnot, where a primary progressive aphasia is identified early, they may progress over time to basically being mute, where verbal communication is non-existent. There are folks also who have prominent behavior symptoms early on, who also stop using language and lose their use of language and become mute. So in Mike's case, the language loss, if the behavior symptoms were early and were most prominent, the language loss there may be a combination of apathy, confusion of being able to, having a harder time processing what people are saying, that causes folks to sort of stop talking. One of the things that can be really helpful in either case is that if an assessment with a speech language pathologist or a speech therapist is possible, that expertise might be able to help identify what are the language skills that are intact and what are the language skills that are lost. And the speech therapist then also is a tremendous resource to try to figure out ways to compensate for the lost skills. So in PPA, a speech language pathologist, especially early on, can be really helpful to learn about strategies for the person themselves to rehearse and to kind of over practice some words that are important in their daily life and be able to kind of preserve some language functioning for a period of time. They're also very helpful in identifying if sort of receptive language or expressive language is impaired more, and can help to develop strategies that the family can use to maximize communication. So when people have more behavioral symptoms and they're just not talking, it's not as clear why, but speech therapists might be able to poke around with that and try to help understand and develop some strategies that could improve communication.
That's a great suggestion, Sharon, to seek out a speech therapist. I don't think I would have thought of that. So that is a great tool to mention here to this audience. So I hope that that question, Mike, helped, or that answer helped your question there, Mike. We appreciate you writing in during this live chat, and kind of along the same thread of losing the verbal communication. We had Amy write in on our Facebook page about her situation with her husband. So she says, my husband is home. He's 66, was diagnosed 4 years ago with FTD dementia, primarily progressive aphasia, and then logopenic dementia. I don't know if I got that right, but I'll continue. He is the sweetest man ever and is now totally nonverbal, but his facial expressions are timely and funny, and they are there. My problem now is how to talk to him. I sort of don't. It breaks my heart, but I don't know what he's really thinking. Are there any guidelines? I do talk about family, weather, food, but I don't really know if I'm missing opportunities or I tend to stay in the present. So she's, I guess her question is around, when that person does lose the ability to speak, are there any guidelines or suggestions for family members on how to continue to interact? Because I know that can be intimidating to just be talking at somebody, or they might feel like they're maybe talking too much or talking too little. So any advice there for Amy, Sharon?
It's a great question. And Amy, thank you for asking this question, because it gives me a chance to pass along things that we've learned from some of our favorite people that we've gotten to know over the years. And, caregivers are really such a great source of both inspiration and practical tips. But one of the examples that comes to mind is a gentleman who was caring for his wife who had exactly this diagnosis of logopenic primary progressive aphasia. And his wonderful approach was all about communication not being verbal at all. And, we know this. We know that, I think the researchers will say that 90% of communication is not verbal, but it's all the other things that go into our facial expression or our nonverbals or other ways of communicating. And the key really is to allow yourself to be creative, to allow yourself to really use your knowledge of your husband and to be able to find ways of adjusting the relationship that isn't as dependent on words as most of us are. And when done kind of within that aura of sort of freedom to explore and to be creative, my wish would be that you'll find that communication can remain really rich and can certainly involve the other person, not in the same way that you've always done, but in a different way, in a new way. And so that there are ways that relationships continue, but we do have to adapt and grow and change based on the reality of the disease. Staying in the present is perfect. That's where you have to stay. And it really does become a matter of continuing to love the person in day-to-day ways, whatever that means for your life together. Maybe it's taking a walk together, not saying anything, but listening to music. Dancing in the kitchen was another example we've learned from this lovely couple. Finding ways of staying connected that don't depend on words. The corollary to that, of course, is that you need support for the loss around what's changing in your relationship, and finding ways to get that support, especially among people who understand what you're going through, is really key. We haven't talked about support yet, Lakelyn, but finding a support group or resources where the folks that you're connecting with understand these disorders is especially important. We hear all the time that regular dementia or Alzheimer's caregiver support groups can be helpful, but people who are younger with different stage of life and different developmental things that they're going through with their family aren't necessarily going to feel as though that's the best fit. There are starting to be more support options for people that are specifically related to FTD or FTD and PPA. And finding a good fit of support is where you mourn the loss of what the disease is causing, so that you can then go back to your relationship with your husband and have a little bit more room to be free and creative, to stay in the present.
Thank you so much, Sharon. I love some of those beautiful examples that you gave of dancing in the kitchen together, using music to still relate to one another. I think that those small things can really, truly be so powerful. And as you were talking about this, I had a flashback to a client that I used to service when I was a client care coordinator. And now reflecting back, he did have a form of probably PPA, the primary progressive aphasia, and could no longer speak, but he loved to play cards. And so when we had caregivers go in there, they would play cards for hours on end. And he, he didn't say a word, and sometimes the caregiver talked, sometimes she didn't, but they really were able to bond over that simple card game. So I love the suggestion that you gave, those suggestions that you gave, and then also to find a support network, because like you mentioned, I've also heard the same, that sometimes an Alzheimer's support group or a more general support group for dementia doesn't necessarily address the specific symptoms or experiences that people have with FTD. So, and I think while we go through the last 15 minutes, I'd like to pull up the resource slide. I feel like I never give people enough time to reflect on that. So as we take a few more questions, I'll have those up, because there's some great resources here. And the AFTD.org website is the association that Sharon is with. And Sharon, if you wouldn't mind talking a little bit about the AFTD Kids and Teens site, because I know you mentioned that FTD affects people at a younger age, and so therefore they're likely to have maybe younger children, maybe teenagers, kids, that the families are having to go through all of this together. So could you tell us a little bit about that site and what people could find there?
Sure, although I'm going to ask you to indulge me one moment before we move on from
Yes,
Amy's
please.
question, because we had mentioned the speech language pathologist or speech therapy earlier, and the other part of what's available to Amy in terms of how to communicate with her husband may be through a consultation with an SLP or a speech language pathologist, in that there are strategies that they can introduce you to use a communication book or build books that are based on pictures and images to facilitate communication that are not necessarily word-based. And so I just wanted to go back and pick up that thread, because it's absolutely all the things we said before, and connected back with the idea that a speech language pathologist can introduce you to additional tools that may be helpful. So that said, moving on to teens. Yes, thanks for asking about this, because we do have a companion website that was designed for children and teens. There are actually 2 sections to it, because as Lakelyn said, we know that, if the average age of diagnosis is in the 50s for someone, there's another range here, much like the length of progression. We know that there are folks who are diagnosed really as young, a couple people as young as in their 20s, late 20s, all the way up to 80. So it's a wide range. But there are lots of people with FTD who are diagnosed in their 40s or late 30s who may have children in the home. And because of the particular burden of this disease on families, for all the reasons we said in terms of how it's different from Alzheimer's, we know that caring for someone with FTD places a much higher burden on the family. Part of that is from the support standpoint and the isolation that people feel. A big part of it is financial. And so families where the main breadwinner is affected and kids are at home, the financial hit is especially huge. We did a study that actually supported the idea, and we have data now that shows that the cost of FTD, because of this loss of income, is really twice that of Alzheimer's disease. And so that might be another question that we come back to. But where there are children at home, you can imagine that the kinds of symptoms we're talking about can have a particularly devastating effect on the family life. lots of the behaviors are really embarrassing behaviors. They're not socially appropriate behaviors. And so being able to, support families through that is really important. And so we have this website, we have some other materials for that. We also have a telephone support group for a parent who may be caring for a spouse with FTD and find that they have children at home. The key is to figure out ways that, one person can't meet the emotional needs of all these people in a family. So figuring out where are the additional resources that can help make sure that the kids have somebody in particular to check in with, and in particular to be able to turn to. Professional counseling is really important, where people are able to access that. And you just need a whole host of supports to make sure that everyone in the family has the best chance of processing the experience, as well as, for kids, so that they can still be a kid and be successful in school and have friends and that sort of thing.
Thank you so much for sharing more details on those resources. It seems like they are probably a very welcomed source of support for these families that are going through all of this, all of these changes in their family structure, and as you mentioned, in their financial situation. And it's so interesting that you mentioned that it costs about twice as much because of these younger onsets and diagnosis. And we know that dementia, overall is a very expensive disease for families and the person living with dementia. So is there any, I guess I kind of want to shift the conversation a little bit to maybe, is there any hope for this arena? Is there any research that your organization is aware of or investing in? Are there, I know you have some great resources here on the slide. Is there anything in terms of research? Somebody had asked a question about this. My mom has FTD, my dad has Alzheimer's vascular dementia combo. There's a lot of research done for Alzheimer's, but none that I really know of for FTD. Our family didn't even know that she was diagnosed with it. So can you speak a little bit about research, or if families that are listening want to engage in research, is there opportunities that you're aware of?
Sure. And this is another really important part of the conversation. So thank you for raising the question of research. Our organization looks at both, and we know that people affected now really need all the support and the assistance they can get. And we also know that there is an awful lot happening in research. And so folks facing FTD should be assured that the research community is actually very engaged and moving quickly to try to exploit everything we can learn about these diseases and be able to move to a point of having some targets for treatment, some drugs that can be tested in the FTD community. There's a lot of studies going on. I actually did a quick look on clinicaltrials.gov, which is a clearinghouse that the government hosts for information on research studies. And right now there are about 50 studies that are currently recruiting or will be recruiting that are related to FTD disorders in one way or another. Now, they're not all drug trials. There are challenges around diagnosis, are also challenges that are presented in the community around developing and designing studies, clinical studies for testing drugs. And so the field is moving quickly and making lots of progress. That being said, we're nowhere near having the drug breakthrough that everybody wants and hopes for. But there is a lot of activity, and there are ways that folks who are affected can be very much involved. And of course, it's even more important in a rare disease that people who are interested in research and who are able to participate, that they do if they can. So a couple of specific things that I'll mention. Our organization is a partner in something called the FTD Disorders Registry. This is an online HIPAA-protected private database for people who are diagnosed with FTD and their family members to self-report, to enter information into the database. It's going to be the central repository for folks to be able to help move FTD research forward. People who are interested in potentially participating in research can indicate that when they sign up at the registry, and then they will have the potential to be notified as studies come on that they might be eligible for, that they might want to consider. So That is the FTD Disorders Registry. If people want to make a note, or again, if you want to contact us at our helpline, I'm happy to point you in that direction. And the other big initiative is that the federal government has funded a clinical consortium that's doing longitudinal studies or observational studies in FTD. And so there are a number of centers across the country that have particular research protocols for folks who are affected by FTD. And as a subset of that, there is a particular study looking at those families where a mutation or a genetic inheritance has been identified. There's a portion of people with FTD who do have a family inheritance of the disease. It's about 10 to 12% of FTD cases are inherited. And folks from those families who are participating in research are really driving a lot of the progress in this field, and their participation, as well as everyone, but their participation is hugely important. It's also those folks, because we can identify the pathology, those are the people who may be eligible for the first drug studies as they come online.
That is all great information. Now, we never even got to the topic of, is this type of dementia generic or hereditary? So I'm glad that you mentioned that, because I know that's a question that usually comes up when we talk about different types of dementia. But that's so wonderful to know that there is progress in the field, and they are continuing to learn more and more about FTD. And you said that we're not close to that medical breakthrough, but it really does take people giving of their time and to these types of clinical studies. So if you are listening and you're able to participate, we'll make sure to include the FTD Disorders Registry information in our follow-up email, in addition to these resources that we have here. So I do want to run through the resources really quickly. We've already talked about those first two, the helpline, and you can contact the AFTD to learn about support groups. And then if you want to learn more about that, Partners in FTD Care, there's information on their site as well. If you want to learn about Home Instead, you can visit our website. If you're feeling the stresses of caregiving, we have a great website called caregiverstress.com with a lot of helpful resources. And then helpforalzheimersfamilies.com. While it's labeled an Alzheimer's support website, we do try to support all types of dementias. And that's one reason we're having a chat on FTD today. So you can visit that page and join our Facebook group. There's the website there. And then there's a great book on the different behavioral symptoms of dementia called Confidence to Care. And you can find out more on that link at the bottom. And then I do want to just give you some quick information about next month. Our chat for the month of March will be strategies to cope with ambiguous loss. If you're part of our email community, we covered ambiguous loss in one of our emails, and we got such a strong response because this is such a pertinent topic that we are bringing the expert to all of you via the live chat. And ambiguous loss really can probably relate to people caring for someone living with any type of dementia, because it's it's geared around the emotions that you feel as you watch your loved one fade away, even though they're physically present. So Sharon, I'm sure that people caring for someone with FTD experience that sort of ambiguous loss. Have you heard much about that in your community, the FTD community?
Absolutely, yes.
And wonderful.
Yep.
Yeah, well, I would definitely encourage you to all tune in to next month. And Sharon, I really want to thank you for your time today. You have been a wealth of knowledge. We have several listeners typing in our chat box. Thank you so much. I've learned so much. Even though I've been dealing with this disease for many years, this 1 hour of information has been so helpful. And I would have to agree with the people that have been typing in those comments. Thank you. And anything else that we haven't covered yet in relation to this topic that you want to make sure that our listeners know about FTD, or any additional resources to share?
I'm really appreciative of being able to be with you, because it does all start with awareness and helping people first to not feel alone if they're dealing with these disorders, to know that they can turn to us for information through the helpline and through other avenues, and we'll try to connect them with things they might need. but also just to try to really keep moving the needle forward on helping folks with dementias of all sorts to get good resources and be able to manage the hugely challenging diseases that they are. So thank you for having us on. I really appreciate it.
Well, the pleasure is sincerely ours. And I want to thank all of you who took time out of your day to join us for this webinar. I mentioned at the beginning that we will be, this was recorded and we will be sending it out via email after. So be checking your inboxes if you want to forward this on to somebody maybe in your family or a friend or somebody else that you know who might benefit from hearing this, this wonderful hour-long chat on frontotemporal degeneration. So thanks to everyone, and we'll see you next month. Have a great day. Bye.